Hello, everyone. Please do take your seats and welcome to this keynote speech from Matthew Swindells. At a time when the NHS is under pressure, how are we doing? What do we need to do to move forward? That is what Matthew is going to tell us. He'll talk for 20 minutes, half an hour, and then we'll have an opportunity for questions afterwards. So do think about your questions. But now, please join me in welcoming Matthew Swindells.
Well, thank you very much, and thank you all for being here. It's a very wide-angle audience. From they say try and maintain eye contact with your audience. Well, over on this side, it's kind of hard, but it's good to be. So yes, what I'd like to do is to talk for a while about firstly, where are we now, and what are the immediate priorities that we need to deal with. I want to talk a bit about STPs and accountable care systems and how I think they are playing into the overall strategy. Then I'm going to talk about information and technology and our wider strategy around that and how it comes together, and then maybe land on the challenge. But I think the first thing I want to do is to say thank you to the NHS staff in the audience. There is no question the NHS is working under a lot of pressure. There is no question that having to work hard in order to provide the best possible care for our patients, and the ongoing commitment, the number of our people who routinely go beyond the call of duty in order to provide the care that people need in hospitals, in the community, in primary care, and in their homes is always awe-inspiring. So thank you. Because despite the pressure that we operate under, despite the challenges of there's never enough money to go around, the NHS continues to deliver. Whilst we want to improve and need to improve our A&E performance. I've come back from 3 years working in the States, and I can tell you that if you go into a big general hospital, into the A&E department in one of the major American cities, you will wait for longer to be admitted to an appropriate bed than you do in a hospital in England today. If you are not fortunate enough to have expensive health insurance in most publicly funded health systems around the world, you cannot go from referral to treatment in 18 weeks in any country around the world, not just in the States, but in Australia and France and Canada and so on. So we are still delivering under this pressure world-class performance. Not all the time, not every time, but overwhelmingly the NHS delivers world-class performance. And that's why the Commonwealth Fund review that you can see the chart here behind me, just a few weeks ago, an American think tank said that looking across 11 health systems in affluent countries, the UK system was the best. And so we should be proud of that, and we should be fighting to make sure that remains true. And I'd go further to say we continue to be probably the most efficient health system in the world. The latest OECD data looking at the amount spent per head of population for healthcare showed that, for instance, if we were to be spending the same amount per head as the French, the NHS would be spending another £15 billion a year. So we do a hell of a lot in an extremely efficient way, and we should be extremely proud of that. But we can't rest on our laurels, because there is a hell of a lot still to do. In July, we had, between ourselves and social care, managed to reduce the number of delayed transfers of care across the NHS this year by 570 between the two parties. We had got bed occupancy to just over 91% against the NHSI target of getting bed occupancy down to 92% in order to be able to create a flow through hospital. But the A&E wait time was still flatlining at 90%, seen and treated within 4 hours. We had the conditions in July to get back to 95%, and we didn't. And we cannot afford to settle for good enough. we need to be better than that. We need to get back to excellence. We need to make sure that we are driving innovation and we are driving at the same time as we are driving basic good practice. We have to get a grip. We have to take the opportunity to make that shift now before we get into the winter, because when the pressure of the winter comes, if we haven't done the work now, we won't be able to maintain the sort of quality of services that we want across the winter. We still have something like 30% of patients in hospital who are stranded in hospital. They need some care, but they don't need to be in hospital. We are holding them in frequently elderly care wards against their will. Again, we are denying people a freedom. And all of these patients aren't waiting for a social care package or for a complex and expensive continuing healthcare package. There are a proportion of patients who are waiting for both of those. But the vast majority of them are waiting for us to get our act together. And I believe that the tragedy of the NHS is elderly care people, people's mums, people's dads, on a hospital ward, deprived of their freedom, unable to live the last years of their life with the best opportunity they can. And we should be focused on that, not because of an A&E target, not because of a bed occupancy number, but because if we want to give people their best possible chance in life, then holding people on a 30-bedded elderly care ward is not your best chance in life. And when we look across our A&E departments, what we do, and we've done this study now across a number of very high-performing A&E departments, about 50% of the patients in A&E could have been treated somewhere else. They could have been treated in primary care, they could have self-cared, they could have gone to a pharmacist. They didn't need what a hospital needs. So while we're investing now in primary care streaming in A&E, while we're investing in urgent treatment centres, while we're investing in extending the access to primary care, we need to actually shift the patients. We actually need to get patients to a more appropriate location. I would like us to be committed to patients who don't need to be admitted to hospital. 100% of them should be being seen and treated within 4 hours. There is no reason why we can't make that happen. If you look across our walk-in centres and urgent treatment centres, many of them are at 99%, 99.5%. When we suck patients into hospitals where there are more complex patients needing more focused time, they end up waiting for stuff that could be done quickly. So we need to grip the transformation that is required. And if, as the Royal College of GPs say, 27% of the patients who go to GPs don't need to go to a GP, we get the story of why we have to have a system shift. Why, if we want patients who are in A&E to be treated in primary care, we need to create the space in primary care by treating those patients elsewhere. It's like one of those little 9-box slidey things where you have one empty space and you're trying to make a picture of the Eiffel Tower out of it. You have to be able to move all of the pieces. If you just focus on a silo, we won't get the shift that we need. But the opportunities are out there, the opportunities for us to think as a system to make the big changes that are necessary. And when you look at the work that Right Care and GIRFT have done, what do you see? Right Care are estimating £2.4 billion worth of potential savings through the removal of unwarranted variation. GIRFT project saying £3.4 billion could be saved between now and 2021 by the adoption of best practice. So this isn't about depriving people of things that they need. This is about giving them the things they need in the right kind of way. And if we don't make those decisions, if we don't take those chances, we end up having another conversation. And we've talked about the difficult conversations that we have to have in order to deliver the NHS that the public needs and to be able to keep a sustainable service. And I'd say to you that we need to consider what we mean by a difficult conversation. Because if the difficult conversation we don't want to have is the one which says clinical practice has to change, and the difficult conversation we are prepared to have is waiting times are going out and you can't have IVF anymore, we're having the wrong difficult conversation. We need to face the service and say, even as the most efficient health service in the world, even as a very high-performing service, we still need to get better. We still need to drive changes. We still need to start challenge the status quo. We still need to remove unwarranted variation in order to be able to do for the public that we serve the things that they have a right to. And it's going to take really good, really brave leadership to make that historic shift. And part of doing that is why we created the STPs and the accountable care systems, because we've changed what the question means to be a really good chief executive in the NHS. Only a few years ago, the measurement of being a really good chief executive was the success of your institution. Now the measure of a really good chief executive is the success of your system. The rules and the challenges that we now face are too complex to be dealt with in silos. We have to work in partnerships. We have to be able to do what Andrew Morris at Frimley says, which is that by working with community and primary care services, he has managed to create an emptier department at Frimley Park and a smaller hospital. The challenge isn't how big is your A&E department, the challenge is how great is your A&E department. The challenge isn't how big is your hospital, the challenge is, are the right people in hospital receiving hospital care? And with STPs, we are trying to bring together systems. We are trying to give permission to make the right decisions. I don't want to hear any more excuses like payment by result makes it impossible for us to do the right thing. The chief executive at the London Teaching Hospital last year who told me that his chairman wouldn't allow them to put streaming into the A&E department because it was on the primary care patients in A&E that they made their profit. That's a dinosaur. We have to move beyond that. The question isn't the profitability of an institution, it's the sustainability of a system and the quality of care that we are delivering. So we're trying to give the freedoms, the permission to say, if I can make my health system balance, let's not get obsessed about individual departments and individual organizations. Let's come together and redesign the system to deliver high quality care for everybody. Let's focus on the people who need it most. Let's deliver excellent care in the right location. And out of the removal of error, the removal of unwarranted variation, will come the savings that we need. And we have to do that now because next year is going to be harder. The financial challenge this year is going to be greater next year. That's why we put in place a 2-year contracting round at this time last year. This year, we have the luxury of not running another contracting round, not waiting for a new set of prices to be published, not waiting for a new set of targets and standards, not waiting for the new sequin rules to appear, but to actually get on with delivering the plans that we started to put in place. Now, I know that year 2 plans were written in pencil rather than ink at this time last year, but we need to now be focusing on what will our system look like in 18 months' time? Am I taking the decisions now that are going to take 12 months to deliver the benefits in order that when I run into next winter, I have done today the things I need for next winter, as well as doing today the things we need for this winter? That's what the NHS asked us for. The NHS said, lift the burden of the contracting round and sending forms up to the centre and let us get on with delivering stuff with a longer time horizon. We now need to get on with it. It's not a pass to not have to worry about next year. This is a continuous set of changes. If our in-year assumptions were wrong in a patch, then we need to take the actions to bring them back into line. If our quips and sips aren't delivering, we need to take the actions to bring them into line. There isn't going to be another roll of the dice to say, you know what, we might get lucky and we might get more money next year, because we know what the allocations are, and now we need to deliver the changes. And we know we can do it because we are already delivering the best value, highest quality health service in the world. The question is, do we want to participate in losing that, or do we want to drive on from there? And I see, as I've walked around here, the amount of innovation that's going on, both in terms of service delivery, but also in terms of technology. I saw My M Health showing their app for supporting COPD, where they've actually done the proper evaluation and published the evidence to show that using their system, people can manage their own COPD and other conditions better. I saw the work that the HSNs in Cheshire and Wirral have been doing with IEG4 to improve the pathway management for people who need continuing health care, making sure that data flows across the system, that we standardize data capture once, that we take the bureaucracy out of the system and focus on getting to the right answer for individuals. And I talked to primary care suppliers who've been much maligned over the years about playing within their walled gardens, talking about interoperability, population health, the need to be able to share data across boundaries, need to be able to create a picture of the health needs of a patient, whether it's in a primary care surgery or somewhere else. And that, to me, is symbolic of the sea change we're seeing everywhere. I've spent most of the last year talking to the 44 STPs. I think I've met them all twice, and many of them many more times like that. We have some brilliant STPs who are at the leading edge of change, and we have some that are struggling to build those partnerships. Nowhere hasn't moved forward. Nowhere doesn't have a better sense of partnership now than it had a year ago. And if we can now build that into the use of technology, the use of IT to accelerate what we're doing, we can make a big change. And that's why this is, we call the IT strategy placemat. This is our IT strategy on a page. The focus, firstly, on patients, on empowering patients to self-care, empowering their carers to look after them, opening up an ecosystem of development so that whilst we centrally will offer everybody access to their data, people can start to create the solutions that work for individuals and to innovate around pathways using technologies. The work that we've done with the GDE program is beginning to really bear fruit. We're out in the first acute hospitals, we're out in the first mental health trusts, we're about to launch GDEs into the ambulance service, and this afternoon the Secretary of State will talk about the next group of fast followers, how we're extending the GDE program to get world-class IT into our providers and away from being trapped in a paper-based nightmare that we often are. But we're also focusing, and we've tried to learn this from the States, where they invested a lot in hospital IT and didn't create a view for population health. In how do we target real change? How do we focus our IT on focusing on the real challenges that the NHS is trying to solve? Our urgent and emergency care strategy, our elective strategy, mental health, women and children, chronic and comorbidities. How do we create better linkage into social care? And how do we create a hub which brings the data together at a local level, building on the best of what's already happening in order to be able to create one view of the patient? And Simon talked in his speech about the innovation hubs. Well, what we want to create are clinical hubs that allow you to treat a patient, that will create anonymized data for research and anonymized data for management. Can we collect the data once and use it multiple times? And that's where we're moving to, so that we can have a single source of truth, so we can move away from management meetings that spend more time talking about what needs to be done and less time talking about whose spreadsheet is accurate. Can we move away from the time that we waste squabbling over coding and have one source of truth that we are all debating for the good of the patient? And can we leverage that to build the future? Can we leverage that to make the NHS a hub of research and developments and genomics and precision medicine to take us forward? And I think we're making great strides there. I think we're moving from press release into real delivery on the ground there. People have been doing a fantastic job. But the challenge for managers now is, how do you build technology into your business strategy? I'm not expecting people to learn this off by heart, but the yellow parts are technology's intervention in a modern urgent and emergency care pathway, from patients being able to access the information to self-care at one point, so that they don't need to access a clinician at all, or can be guided to a clinician, that they can access a clinician over the phone through 111 as we move that less from triage and more into call and consult, where a clinician on the phone can access your medical record with your permission, can directly book you to see a GP, or can directly book you into an urgent treatment centre, but can also write you a prescription. The number of appointments that follow at 111 call because somebody now needs to go to their GP in order to get a prescription filled is, we can just strip that out by using technology, and we can prescribe to patients the information that they need. So we now need every board to put IT at the top of their agenda, to be thinking cybersecurity, to be thinking service redesign, to be thinking data quality, to be thinking data capture, thinking how do I use the new technologies to drive the changes I'm making rather than IT being in a corner. And the challenge to the IT department is to get out and be part of that innovation, to get out and actually be making the case for how we can use technology to transform care. And the challenge to every organization and every vendor is to be open, is to not be protective about your data. The data belongs to the patient. And if the patient wants you to share what you've got with another clinician who's treating them, I don't want to see vendors locking the data down, and I don't want to see hospitals treating patient data as if it was some sort of market opportunity, because that's not the NHS that we are. The NHS that we are is around the health of populations. And it's important because working together is working, that we know, here's some of our best examples, but right across the country, these are examples from accountable care systems that we know are doing fantastic stuff. Life West Berkshire, which for all of the patients who have been referred to a shared decision supporting process, prior to having joint surgery, 80% of them choose not to have surgery. Flip the other way round, 80% of patients are currently having a knife taken to them by a guy wearing a mask or a woman wearing a mask because they didn't understand what was about to happen to them. There ought to be a law against that sort of thing. So we need to be able to leverage the best of what's going on. But you don't have to be one of these elite health systems. You can be one of the ones that are dealing with tough problems and are trying to lift themselves out. I was on the Isle of Wight, where the work that they're doing with the police to keep mental health patients out of police cells is spectacular. If you talk to Surrey and Sussex Hospital about the work that they're doing with building contractors around creating homes that are healthy, we all have an opportunity to do a transformation. We all have an opportunity to make people's life better. And I would land by saying, or I'll land by not putting up a last slide. Land by saying, do we believe we can do it? I believe we can do it. I think the technology is becoming real rather than a press release. I think we have a sense of focus and a sense of partnership re-emerging in the NHS, which plays to our core values, that we have a sense of focus on the patient, which is making a huge difference, and I'm seeing that across the country. Really hard problems being solved in our most challenged health systems by people coming together across their institutions. I think we have the best leadership and the most committed staff in the world, and that's why we have the NHS that we have. And to quote Simon from this morning, on the eve of the NHS's 70th anniversary, the future is in your hands. Thank you very much.
Does anybody have any questions for Matthew? Stick your hand right up so the people with the microphones can find you. There's somebody over here. Anybody else? Just one. No?
That's the other one in there.
Yes, two. Yes. So I'm going to take these questions two at a time. If you could ask your question and then pass the mic back to the gentleman behind you, that would be great.
Hi there. So my name's Nick Chin from Premier IT, one of the swathes of small agile IT companies trying to prop the NHS up. That was the first time that I've heard anybody note that current IT vendors are locking data down. How can we empower staff to not buy IT that doesn't work? So that's my first question. Okay. Do you want to pass the microphone back to the gentleman behind you?
Yeah, Ben Heather here from HSJ. So I was just interested, obviously winter's coming, and you talked about the need to get on with transformational change. Not a huge amount of time to do that. What are the kind of the things that trust should be really focused on in the kind of short term before winter in terms of making those transformations that need to be made?
Thank you for asking Pauline's question for her because she couldn't come. She'll be very grateful. So to pick up on the IT one, I don't think any of our staff go out deliberately to buy IT that doesn't work. So I think the challenge, which I believe the industry is now picking up, is that we need to create a view that is wider than individual institutions. And I think it's two parts to that. One is that data needs to be opened up, and in our GDE programs, and as we go back out to procurement to refresh the GP systems of choice, we will be making open data, interoperability, secure access to patients' data a requirement from all of those systems. And as we put our regional interoperability hubs into place starting towards the end of this year, we're going to be really clear about which vendors are sharing and which vendors aren't. So because with the adoption of international standards, we are expecting to be able to both get away from half-baked systems that do half a job and into solving real complex problems, but also creating the space within that for small vendors to be able to innovate. And I've just come here from meeting with the US Department of Health. Interesting opportunity to meet with President Trump's appointed IT advisors. And it turns out they're not mad. They know a lot about this stuff, and they also are interested in interoperability and data sharing, and how do we create an international market that allows the best vendors to be able to innovate on the edge. So I think we need to be really grippy about this. We need to not take any shit, and we need to drive openness and data sharing into the system. In terms of winter. Very good. I like that. In terms of into winter, I think people know what they need to do. We need to drive the urgent emergency care strategy into place. We need to get 111 that is dealing and solving with people's problems. We need to get our urgent treatment centers open and operating and providing a standardized service, and for patients to know about it. We need to make sure that we have primary care cover across the winter period and that people know where to access it. There was a bit last year where we had a lot of primary care open and people assumed it wasn't and went to A&Es anyway. We need to make sure that when people are giving up their time to offer services to patients, patients know how to get to them. We need to get the streaming into A&E so that A&E doctors are treating patients who need to be in A&E, and that we have a primary care service alongside it. We need to get our discharge strategy and discharge to assess into place, and we need to drive through hospitals really good practice. We need to make sure that A&E problems are not the problem of the A&E department, they are the problem of the whole of a hospital, that we are viewing the flow of patients through, the right patients being in hospital at the right time, as being the core business of the hospital. I think that strategy is out there. I think people understand it. I think we need to make sure that we don't hit the targets and miss the point. We don't open urgent treatment centers that more people don't use, that we don't create streaming services that people don't use. We actually need to move the flow of patients.
Excellent. Do we have any other questions?
One here.
No?
Who else does interoperability and A&E redesign in the same speech?
Frank Brown, I'm on my patient GP patient reference group.
Mm-hmm.
About all the innovation in primary care services, just how do you get the message out to patients in the community about all these services that are available?
Well, I think there's two elements to that. The obvious answer is we need to use the mechanisms that are there to tell people. I would like to be able to wander in November into any town in England and be able to see on the side of the buses clarity about where you go on Boxing Day if you need primary care. I'd like it to be on local radio. I'd like it to be in the local newspapers. I'd like it to be pushed out through Facebook and I'd like us to be marketing the services that are on offer, because we need to understand that different people need to access information in different ways. I think in terms of access to the technology, we need to make it much easier for people to access their record, book appointments, communicate with their GP online. When I came about 18 months ago, we were trumpeting that. I'm not exactly accurate about the data, but we were claiming 93% of people could access their GP record, and then in little subtext at the bottom it said 2% do. Mm-hmm. I'm not interested in the 2% in the 97% can. I'm interested in how many people are actually using it. And so we need to focus on, are we affecting the experience of people in their lives, not on, have we ticked the box that we made something available? And I think that's a big change we've seen as we've been realigning the IT strategy, which had all the right stuff in it around the set of changes the NHS needs to do. The question is, are we actually doing anything as in terms of the way the NHS works and the experience for patients, rather than just the... and that's an IT thing just as much as it's these services are available to you thing. The question is, do the patients understand it, and can they access it, and are we reaching the people we need to talk to, not have we fulfilled some pledge somewhere?
Anybody else?
There's one in here.
One over here? Yes, thank you.
I just wondered, given that workforce accounts for so much of NHS spend, do you think we're doing enough about the workforce and the workforce for the future and keeping good people? A lot of the reason that some trusts will be struggling is vacancy rates as much as anything else.
Yeah, I mean, I think that workforce is our single biggest challenge at the moment, and I think there's two aspects to it. One is retention, motivation, optimism, the things that leadership needs to deliver to the service. We drive the NHS very hard. We need to remember to say thank you. We need to remember to celebrate what we're doing well as investigate when things go wrong. We need to create an environment where people are proud and optimistic about working in the NHS. Because however hard we work on recruitment, if people are leaving us faster than that, then the bath is going to end up empty. So I think there's a huge focus we need to make on retention, on being creative about flexible working, about giving people the opportunity to work in the right way. And then I think we need to be thinking about the vacancies that we have. Firstly, we need to ensure that everywhere across the country, we have really good bank systems so that we're not dependent on the high rates that we pay for agency workers coming in, much of which isn't going into the pocket of the worker, but is going to the pockets of the agencies. We need to have banks everywhere, and we need to start thinking bigger than just institution by institution. We have occasions which I think is unacceptable, where we're saying this A&E is bordering on unsafe because it can't be staffed, and down the road there's an A&E that's fully well staffed, and we're going, oh no, these staff belong to one place rather than another. So I think we need to be thinking about our workforce at an STP at a system level as well. And then we need to drive the recruitment, and we need to get people into training, into workforce, back into the workforce, and creating that environment. And given that what we pay people is outside our direct control, what is in our control is the experience of working for us, and people wanting to be in the NHS and feeling valued and wanting to stay. And I think we can all do something about that.
We have time for one more. One more?
Nick.
Okay.
Matthew, hi, Nick.
Hi.
Just wanted to take you back to the winter planning stuff.
Yes.
And you talked about 30% of people being in hospital that didn't need to be there. And earlier we heard Simon talk about the difficult time they'd had in Australia and New Zealand with flu and those sorts of things. I wonder, I was just thinking that we don't have a fantastically high uptake rate of things like flu vaccination for either staff or the public. And what are the things that you think people can do to prevent people turning up unnecessarily with avoidable illnesses, like the flu jabs, like helping old people on cold days put their bins out so they don't fall and break their legs? Because surely that must be as important a part of winter planning as any of the stuff just focused on flow.
I think it's an important point, and I think that is part of the flow. The flow is getting ahead of the curve, so it includes the public health message. It means running effective vaccination campaigns and driving that up, making sure that all of our staff are vaccinated, not half or whatever. We did terribly well because we got lots of people vaccinated. Well, why don't we get them all vaccinated? And getting the message out to the public and making it easily accessible, to people who have difficulty getting out of their own homes, but they can get to Boots, but they can't get to their GP. We need to be creative about those things happening. We also need to not let winter take us by surprise, because it comes at about the same time every year, which means that how are we preparing for the capacity that we will need for winter? And if we do get hit by flu, we're going to need more capacity than last year. And if a third of our beds have got people in them who are having their liberty deprived, are losing their health whilst they're in hospital, and if they hang around for long enough are likely to contract an infection, maybe we should do something about that. And that's going to require system thinking, because some of those things are outside the control of any individual in the system. It requires hospitals, community services, primary care, social, to work together to solve that. But I'd like us to be focusing not just on the detox target, but on how do I release 300 beds in my 1,000-bedded hospital between now and winter. And if we set that as our aspiration, we might not get there, but we will get a lot closer than if we ignore the problem.
Thank you so much, Matthew,
been a pleasure.
for
Thank
such
you.
an enlightening and wide-ranging speech. Join me in a round of applause for Matthew.
Thank you.